Let's go over the warm-up review. First question, describe which light reflexes would be seen in both eyes if the right ocular motor nerve were damaged. So this is known as an efferent defect. The right eye will not respond to light shown in either eye, but the left eye will constrict when a light is shown in either eye. Next, what's the differential diagnosis for eosinophilia? Well, our mnemonic is Canada P, which stands for collagen vascular disease, atopic diseases, neoplasms, Addison disease, drugs, acute interstitial nephritis, and parasites, especially those helminth infections. The last one, what substances act on smooth muscle myosin light chain kinase, and how do these affect blood pressure? So the three substances we discussed are dihydropyridine calcium channel blockers, epinephrine, acting at the beta-2 receptors, and prostaglandin E2. And then all these affect blood pressure by lowering blood pressure. Even epinephrine, when it acts at beta-2 receptors, that causes vasodilation. Now we're ready to start the lecture.
Oh, I'm afraid you've caught me at home. Hello everyone and welcome to our Step 1 video on water-soluble vitamins. Please excuse my casual attire. When I get off from a hard day's work at DIT, I just like to come home and relax, like just hang out with my tigers. This one's named McInnis. He's not very bright. Now I've just got to say, you've all done an amazing job studying so far. And because you're such an impressive student, DIT is going to send you a tiger.
No, we're not.
Travis, how'd you get in my house?
We don't have any tigers.
What do you mean we don't have any tigers?
We just don't.
Well, just go down to the store and get some.
You can't just buy a tiger at the store.
Sure you can. Just talk to the guy, ask him if they have any in the back or something. Put out a little effort, Travis. This might be why you don't have any tigers.
Whatever.
Students, don't worry, I'm all over this. And remember, in life, never settle for anything less than tigers. Okay, so in this video we're going to talk about our water-soluble vitamins, which includes basically all of the B vitamins. It also includes vitamin C, but since we've already talked about vitamin C in some detail with the antioxidants, we're really just going to talk about the vitamin Bs today. So let's start off with vitamin B1. So that's our first vitamin, and it is thymine. Now the active form of B1 is actually thymine pyrophosphate, and actually has a ton of important functions. So think about the conversion of pyruvate to acetyl-CoA. That's going to be catalyzed by pyruvate dehydrogenase. Thymine is a very important cofactor there. Alpha-ketoglutarate to succinyl-CoA. So that's going to be catalyzed by alpha-ketoglutarate dehydrogenase. You can use the mnemonic tender loving care for nobody for the required cofactors for both that pyruvate dehydrogenase and alpha-ketoglutarate dehydrogenase. Well, the thymine is the tender, the T in that mnemonic there. Then another one, ribose 5-phosphate to glyceraldehyde 3-phosphate. That's going to be catalyzed by transketolase. And that's actually in the pentose phosphate pathway. And that reaction, again, requires thymine. So very important stuff that thymine does. So you do need to know those enzymes. But even more importantly, you need to know what happens with thymine deficiency. So a thymine deficiency occurs in the setting of poor nutrition. So think of an alcoholic patient who's not eating very much. Malabsorption is another big one. Or increased water loss due to dialysis. Now, as we saw before, thymine is extremely important in oxidative metabolism. So if you don't have thymine, then you can't break down glucose and form ATP. So organs like the brain tend to be affected first with a thymine deficiency. Also, in the absence of thymine, there tends to be damage to the medial thalamus and the mammillary bodies of the posterior hypothalamus, as well as generalized cerebral atrophy. So patients can get what's called Wernicke-Korsakoff syndrome. This material is actually covered in the video with alcoholism as well, but we'll cover it here too. Now, Wernicke-Korsakoff can be confusing because it's actually two different syndromes, each representing a different stage of the disease. Wernicke encephalopathy is an acute syndrome. Korsakoff syndrome is the kind of chronic neurological condition that usually occurs as a consequence of that initial Wernicke encephalopathy. So first, what is that Wernicke encephalopathy? Well, the classic triad is encephalopathy. That makes it easy. You get some ocular dysfunction. You also get some gait ataxia. But patients can also have things like stupor, coma, hypotension, and even hypothermia. Now, Korsakoff syndrome, as we said before, is that chronic consequence of having a Wernicke encephalopathy, and it has several symptoms as well. First is memory loss, and that includes a retrograde and an anterograde amnesia. So you can't remember things in your past, nor can you create new memories. Confabulation is another big one. So patients just sort of invent memories that he or she is going to believe that are true. It's actually trying to fill in a lot of those memory gaps. You also see some personality changes, some apathy as well. And just to make things a little more confusing, in addition to Wernicke-Korsakoff, patients can also get what's called beriberi. Now, historically, beriberi is seen in areas where people's primary food source is a polished or dehusked rice. So when you remove the husk, you actually remove the thymine from the rice. Beriberi is described as either wet beriberi or dry beriberi. Dry beriberi symptoms include things like non-specific peripheral neuropathy with a myelin degeneration. You get toe drop, wrist drop, foot drop, so a lot of drops. You get generalized muscle weakness. You get hyporeflexia and even areflexia. Now, what characterizes the wet beriberi? So you have a lot of peripheral vasodilation, and that actually leads to a high output heart failure. So you get a lot of peripheral edema. You can also have cardiomegaly as well. So dry beriberi is involving the nerves. Wet beriberi is involving the heart. What about treatment? Treatment will involve immediate thymine supplementation. Now, one very important treatment point is that giving glucose to a thymine deficient patient can actually worsen the Wernicke encephalopathy. So anyone who is at a risk of a thymine deficiency should always get thymine before glucose. Let's move on to vitamin B2. B2, also known as riboflavin. So there are two biologically active forms of riboflavin. So the riboflavin can be flavin mononucleotide, so FMN, and you can also have flavin adenine dinucleotide, so FAD. Now, both of these are cofactors for redox reactions. So if the enzyme has the word dehydrogenase in it, then it likely requires B2 as a cofactor. Now, what are the symptoms associated with riboflavin deficiency? Well, patients will have dermatitis, angular stomatitis right in the corners of your mouth there, glossitis, so kind of a smooth, sometimes red, sometimes purple looking tongue. Let's move on to vitamin B3, also known as niacin. So B3 has two active compounds. There's nicotinamide adenine dinucleotide, so NAD, and then you have nicotinamide adenine dinucleotide phosphate, so NADP. Now, these are important again in redox reactions. Now, you might remember from our lecture on amino acids that these are derived from tryptophan. So you can actually make your own niacin if you have enough tryptophan. Now, what disease is caused by niacin deficiency? Well, it's pellagra. So here you have your 3 Ds of vitamin B3 deficiency. So the 3 Ds are dermatitis, diarrhea, and dementia. Now, vitamin B3 deficiency can occur from a dietary deficiency. Also important to remember here that pellagra can be caused by heart-nut disease. You actually get decreased tryptophan absorption in that situation. You can have malignant carcinoid syndrome. In that case, you actually have increased tryptophan metabolism. And then also a drug, INH, which actually inhibits both B6 and B3. Moving on to vitamin B5. So B5 really isn't as high yield as some of the other B vitamins, also known as pantothenate. So it is a compound of coenzyme A, which functions in the transfer of acyl groups. Now, if deficient, then you can see some dermatitis, some enteritis, which is a little different here. Alopecia is a little new, and then adrenal insufficiency. And that's about all I would know about B5. Moving on to vitamin B6, also known as pyridoxine. So the active form is pyridoxal phosphate. So what is the metabolic function of our pyridoxal phosphate? Well, it's a coenzyme for numerous enzymes, including those of amino acid metabolism. So think about transaminations and deaminations. B6 is also very important in converting amino acid precursors into a lot of stuff. Things like into heme, niacin that we just talked about, histamine, GABA, dopamine, norepinephrine, epinephrine, a lot of stuff. Now, what are the clinical findings of B6 deficiency? Well, you'll see many of the same symptoms as riboflavin deficiency, things like that angular stomatitis around the lips, the glossitis of the tongue as well. But one thing that's unique to B6 deficiency is things like convulsions or seizures and hyperirritability and peripheral neuropathy. And those convulsions occur because B6 is actually essential, as we said before, to the creation of GABA. And that's the main inhibitory neurotransmitter of the brain. GABA keeps the brain quiet. Now, as we just saw with vitamin B3, INH or isoniazid can induce a deficiency of B6. So if a patient is receiving treatment for tuberculosis, then we often add on vitamin B6 as another treatment option. Moving on to vitamin B7. B7 is biotin. So what's our metabolic role here? Well, it's an apoenzyme for carboxylation reactions. So if you want to add CO2 to something, then you have to use biotin. Also, if you see an enzyme with the word carboxylase, that's another clue in there. It's going to require your B7 or your biotin as a cofactor. Now, what can cause a deficiency of biotin? Well, there's a glycoprotein called avidin, and that's found in egg whites, and actually prevents absorption of biotin. You actually have to eat quite a few egg whites for that to take place, but that's still pretty interesting. Antibiotic use can also result in a biotin problem as well. Moving on to vitamin B9, folic acid. So folic acid, big one here. Simply put, folic acid is crucial for the synthesis of DNA and the repair of DNA. Also especially important in the synthesis of purines and pyrimidines. Folate is also very important for rapid cell division and growth. Its biologically active form is the tetrahydrofolate, which is a coenzyme for one carbon transfer or methylation reactions. Now, humans are actually unable to synthesize their own folic acid, therefore we have to get our supply through the diet. Now, let's get into the fun stuff. What about folic acid deficiency? How does that occur? Well, most of the time, folic acid deficiencies are due to medications or malnutrition. Drugs like phenytoin, sulfonamides, trimethoprim, and methotrexate can all cause a folic acid deficiency. Now, what's nice is that you can actually counteract these effects by just giving supplemental folic acid in most cases. Now, folic acid can also be low in pregnancy because of that rapid growth of the fetus. And the fetus is requiring a lot of that folic acid to rapidly divide its cells. But what are the consequences, again, of that folic acid pregnancy, especially in pregnancy? Well, if the folate deficiency happens in utero, then the baby might develop a neural tube defect. And folate deficiency is the most common cause of neural tube defects, and that's why it's very important to supplement that folate before a woman actually plans to become pregnant. Now, as an adult and also as a child with folate deficiency, you can have a megaloblastic anemia because folate is essential to rapidly dividing cells. Then there are some other non-specific findings, glossitis, similar with our other things, diarrhea, depression, and confusion. I want to take just a very brief moment and talk about megaloblastic anemia here. So this is an anemia, but the RBCs are very large. You have a type of what we call macrocytic anemia, which means large red blood cells. And this anemia is characterized by an elevated number of megaloblasts in the marrow. Now, under the microscope, you might often see hypersegmented neutrophils and then again those large RBCs. Now, including our folate, what's the other vitamin that can lead to a megaloblastic anemia? That's going to be B12, and that's one we're going to hit here in a second. So B12, also known as cobalamin. And B12 is, again, a very important vitamin because B12 is a cofactor with homocysteine methyltransferase to convert homocysteine to methionine. Also in the process, a tetrahydrofolate is produced. Where did we just see that? Remember, that's the active form of folate, so they are related there. Also, the conversion of methylmalonyl-CoA, MMA, to succinyl-CoA requires B12 as well. So what are we going to see with a B12 deficiency? Well, just like with our folate, we just talked about megaloblastic anemia, those hypersegmented neutrophils. Patients can also have neurological symptoms, including paresthesias, ataxia due to loss of vibration and position sense, memory loss, dementia, severe weakness. Now, many of these symptoms seem to be linked to a defect in myelin formation that occurs with that B12 deficiency. Now, this is another actually big differentiating characteristic from folate deficiency. Both B12 and folate, as we talked about before, causes that megaloblastic anemia, but only B12 deficiency will have neurological symptoms. So how does one become deficient in B12? Well, first you need to know that B12 is only found in animal products. So strict vegetarians or vegans can actually have a problem with low B12 if they're not supplementing. Next, you need to know how B12 is absorbed because the most common cause of B12 deficiency is improper absorption. Now, B12 is found to intrinsic factor in the duodenum, and then that complex together is then absorbed in the terminal ileum. Now, the intrinsic factor is produced by parietal cells in the stomach. So an important cause of B12 deficiency is what's called pernicious anemia. So this is an autoimmune destruction of gastric parietal cells and antibodies against intrinsic factor itself. Now, without those parietal cells, the body can't produce intrinsic factor, and without intrinsic factor, B12 cannot be absorbed in the ileum. Now, a similar scenario can occur with gastric bypass surgery. If you remove enough of the stomach, then you decrease the amount of intrinsic factor as well. Now, other causes of B12 deficiency include malabsorption problems like Crohn's disease, celiac sprue, and enteritis. Anything that can cause interference in the terminal ileum can impede the absorption of that B12 intrinsic factor complex. So how do you treat a B12 deficiency? Well, if you're able to absorb B12, then you can just give oral supplements. But we'll probably at least start with an IM dose of B12 to get people started. Now, how would you know if this B12 deficiency was from pernicious anemia? Well, you can check for antibodies to that intrinsic factor. That was one of the pathological problems there. Also, you can perform what's called the Schilling test. So this is where you actually give a patient radio-labeled B12, and then you test to see how much shows up in the urine. If the urine B12 is lower than you should expect, then you might have an absorption problem because it's not going through your body. All right, so before we get to that end of session quiz, let's do another Lewis Notes because, man, that is a lot of material. Hello everyone, welcome to another Lewis Notes. We're going to cover these vitamins again. We're just looking at some of the high points again, not every detail, but enough to remember some of the high yield stuff. So let's go through these. First, over here on the right, we're going to be taking these and matching them again. So first one, we have cofactor with homocysteine methyltransferase. So this is a hard one to remember, but this is actually vitamin B12. So B12 is going to go over here. Remember with B12, you're going to get that megaloblastic anemia, that peripheral neuropathy. Next, we have NAD, NADP on redox reactions. So that's going to be your B3. That's going to go right there. Component of coenzyme A. So that's going to be vitamin B5. That one's hard for me to remember. B5 is not as commonly thought of. And if you get a deficiency, you're going to get some dermatitis, some enteritis, some alopecia, maybe even some adrenal insufficiency. Next, we have good old-fashioned Wernicke encephalopathy. That one's relatively easy. That's going to be your thiamine deficiency, your B1. Think of Korsakoff syndrome as well with that one. Next, we have production of heme, niacin, and GABA. You could also put in there histamine and dopamine and even norepinephrine and epinephrine. That's going to be vitamin B6. Remember that you're going to get a deficiency of that potentially with tuberculosis treatment. So if you're using INH, you also need to use B6 because they can lose that B6 in that medicine right there. Next, we have FMN, FAD, redox reactions again. So redox reactions, when we say that, we mean dehydrogenase is a good example of that. So that's going to be your B2. And then with B2, you might get a dermatitis, angular stomatitis, some glossitis as well. Another hard one for me to remember is carboxylation reactions. That one's just a memorization thing here. That's going to be B7. Nothing else too interesting with that one. And then finally, we have synthesis of purines and pyrimidines. That's going to be your B9. That one's also important with DNA repair. And you might see this with deficiency with drugs, things like phenytoin, sulfonamides, trimethoprim, methotrexate as well. So that's folic acid. So in pregnancy, you're going to see neural tube defects. You're also going to see some megaloblastic anemia as well. All right, guys, so those are some of the high points for our B vitamins. I'll see you next time. All right, it's time for another end of session quiz. Try to answer those questions on your own and then we'll go through them together. First question, a patient presents with convulsions and irritability. What vitamin deficiency is causing these symptoms? So the thing you want to think about is that convulsions. Think about vitamin B6 because that's the one that produces the GABA. Next, what type of anemia can be caused by folate or B12 deficiency? So that's that megaloblastic anemia. Next, where is B12 absorbed into the circulation? So you got to think about the terminal ileum. Remember, that's that complex of B12 and intrinsic factor. Next, which vitamin deficiency matches each of the following descriptions? So first we have peripheral neuropathy and glossitis. Think of B12, also think about B6. Neural tube defects, that's going to be your folic acid or folate. Dermatitis, diarrhea, dementia, those are the big three Ds. Remember, that's B3 or niacin deficiency, which is also referred to as pellagra. Next, we have megaloblastic anemia. We've touched on this many times. Remember, it's going to either be folate or B12 deficiency. Pernicious anemia, remember, that's just specific for B12. And then last question here, which vitamin matches the following statement? So first we have used in oxidation reduction reactions. That's going to be vitamin B2, riboflavin. And remember, that's necessary to make that FAD and that FMN. And then also think about vitamin B3, niacin, which is used to make that NAD or NADP. Next, we have used in carboxylation reactions. So this is Biochem. Now, we didn't talk about this other one. Actually, vitamin K is actually a cofactor for gamma carboxylation of glutamate. But think about biotin as the answer to that question primarily. Next, requires intrinsic factor for absorption. That's B12. Used by pyruvate dehydrogenase and alpha-ketoglutarate dehydrogenase. That's going to be primarily B1 thymine. Next, we have deficiency can be caused by isoniazid use, so primarily B6, but don't forget about B3 niacin as well. Next, we have cobalt is found within this vitamin. So we actually didn't talk about this one in the lecture, but it's vitamin B12. B12 is also called cobalamin, so that association shouldn't be too difficult. Next, we have critical for DNA synthesis. I want you to think about folate and B12. All right, that's it for the end of session quiz. We do have a couple rapid fire facts. First we have here is most common vitamin deficiency in the U.S. That's going to be folate deficiency. If you see hypersegmented neutrophils, that's a feature of megaloblastic anemia from either B12 or folate deficiency. And then we have dilated cardiomyopathy, edema, and polyneuropathy. That's going to be wet beriberi, which is due to thymine or B1 deficiency. All right, that brings us to the end of the video. I hope you learned something. I'll see you next time.